Welcome to our GC Club webinar, Malocclusions in Children and Obstructive Sleep Disordered Breathing, presented by Dr. Ramirez. So as usual, I'd like to give a big shout out to our many partners and thank them for all the work they do in the services they provide and the products that they develop and make available to us so that we can do a better and better job taking care of our patients. Little reminder, those of you that are Z Sleep Club members, prior to any Z Sleep Club Study Club event, you will get a join link so that you can join. And of course, all of these events are BYOB. And if we are hosting a webinar like tonight, you're not getting a join link, you're getting a registration link. So you must register for it, just like everybody else. Once again, BYOB. Little housekeeping, basically select your computer or phone call. At this point, we're all well acquainted with this environment. Your questions, please post them. And either they'll be answered in the post itself, or we'll get to them at the end of the webinar. We won't be entertaining questions through the webinar because that just helps it run that much smoother. And you have your hand up if you want our attention in any way or draw our attention to a question that you've posted. And you can minimize or expand the dashboard with this little orange arrow. And your CE certificate, very important, AGD credits, they'll be emailed in approximately a week. Now, you need to answer the questions at the end of the webinar, including providing your AGD number and your dental license number in order to get those CE certificates. So please take a moment, won't take long at all, to answer those questions and we'll get them out to you. So malocclusions in children and obstructive sleep disordered breathing, sort of connecting the dots, I believe was the end of that title, just a bit on the long side. And Dr. Herman Ramirez is really quite a fascinating individual. He's a dentist, practicing a pedodontist here at Aurora, Ontario. He's worked in many countries, and he's got a PhD, a couple of masters under his belt. He's had ortho training, and he's written a textbook entitled Early Treatment of Malocclusions, Prevention and Interception in Primary Dentition. So he really is very well versed in this field that is a bit on the controversial side, where we have adults being managed for sleep disordered breathing and we have children being managed for sleep disordered breathing, and it really is a different thing. And what he brings to the table is a level of knowledge with regards to children that I think is very hard to beat, and is very evidence-based, literature-based. And I know that it's a controversial area with regards to the role that orthodontics plays in this field, but I think this gentleman does a pretty good job representing what we do know in the literature, what we can say, and really what we're doing when we're helping these patients, and framing it in such a manner that I think would fly with, for instance, our local college, the RCDSO, which is a very conservative entity. So at the end of the day, it's not overstating things and stating things a certain way. Interestingly, American Dental Association wants us involved in our children's airways and the growth of development of those airways. So I think this is a very interesting presentation, definitely out of my wheelhouse, not my area of expertise. So I'm going to be listening intently. Without any further ado, Dr. Herman Ramirez, please, if you could share your screen, I'm going to make you presenter and we can get started.
Thank you for your introduction. Let me share my slide. So now you are seeing my slide.
Yes, we are.
Okay. So let me minimize here. If I can move here. Okay. So trying to minimize this. Going to the other side, but anyway. Okay. Good night, everybody. It's a pleasure, and thank you, John, again for inviting me to do this presentation. I would like to share a little bit of my experience. As John mentioned, I am a dentist working here in Ontario, Canada. I am located in Aurora, Ontario, but I am originally from Colombia, South America, where I did my dental degree. And after I did my dental degree, I went to Mexico to do pediatric dentistry. And from there, I had a training in functional orthodontics in Brazil. And I started connecting pediatric dentistry with orthodontics. And probably, if you ask me, I am one of those rare guys who, instead of staying in orthodontics, I relapsed to pediatric dentistry because I really love working with children. And I don't like to work with adults. Adults are very complicated people. So kids are very easygoing, and I enjoy doing that. But trying to apply orthodontics in pediatric dentistry and trying to start very early treatment, I decided to move to Australia, where I did a master in oral biology. And then I did my PhD, a doctorate in oral biology. And from Australia, I moved here to Canada, where I started doing a little bit of research at the beginning. And I went to the US teaching at Marquette University for a while. Then I moved to Manitoba, where I was teaching at the Faculty of Dentistry of the University of Manitoba. And in between there, I did a master in craniofacial pain and sleep apnea in Tufts University in Boston. So I have tried to put all these ideas together. And that's why briefly I want to share with you today, because it's a very broad field and a very new field. So whenever I am thinking about this, I talk with my patients, and one of the things that I try to do is to make the things as simple as possible. And this is a sentence that I use with all my patients, and I say, okay, the nose is for breathing and the mouth is for eating. And even the young kids, they start looking at me and saying, obviously. And I say, really? But look at you, you are with your mouth open. So do you put food here in the nose? And they say, no. So why do you put air in your mouth? And that starts making sense for them, right? So for me, mouth breathing is one of the first red flags that we dentists should start looking at, because mouth breathing is not normal. And people start asking, and the parents start asking me, really? It's not normal to breathe through the mouth? I say, no. Why do you have to breathe through your mouth? You have the nose, which is the normal way to intake the air into your body. And in that way, we start talking and we start elaborating what could be the problems of the child. And this is a very interesting paper. I'm going to try to show a lot of literature to give you an idea, because many people are discussing about this. Many people are trying to show that they are doing treatment for pediatric population, but everybody is looking for obstructive sleep apnea. And obstructive sleep apnea in children is very, very rare. It's about 3 to 5% of the population, of the young population with obstructive sleep apnea. And this is a guideline from the American Academy of Otorhinolaryngology, from the ENT people. And they are saying obstructive sleep disorder breathing is what we should start looking at in children. because we have a lot of children with symptoms, snoring, mouth breathing, and shortness of breathing. And those kids are not still an obstructive sleep apnea patient, but they have a problem. They have an obstructive sleep disorder breathing. And this is what we start looking at the child. And mouth breathing is the major concern. If we have a parent, a mom or a dad say, my child is snoring at night, and we have the child in front of us with the mouth open, and it doesn't have to be with the full mouth open, but the lips apart, and we see chest breathing, that child is having a problem. And mouth breathing is in our field in dentistry, right? So we need to start looking at that. And that is one of the problems that we see in every entity when we are talking about breathing disorders. If we have a person, even a child or an adult, who is snoring, normally that patient is mouth breathing. If we have a patient with upper airway resistance syndrome, that patient is mouth breathing. If we have a child or an adult doing apneas, that person has a mouth breathing. So mouth breathing is the first red flag that we should start working with. And we are going to treat it. We are not treating an obstructive sleep apnea. And in that I want to be totally clear. We are treating a mouth breather who is a person or a child who has a sleep and breathing disorder. So reestablishing nasal breathing should be one of our goals in dentistry. So this is a big discussion today. If I have a craniofacial disturbance, are they associated with breathing problems? And I'm going to try to elaborate a little bit on this question and to see if we have evidence in the literature. So if I have a child with the lips apart, these kids are mouth breathers. That should catch my attention immediately. I'm going to treat a structural problem that could be a malocclusion, but I'm going to reestablish a correct nasal breathing. I'm going to reestablish a correct swallowing, a correct position of the tongue. I don't want the tongue between the teeth. And if I have a structural problem that could be affecting the airway, I can correct that structural problem and give the opportunity to the child to develop a better airway. But again, I'm not treating obstructive sleep apnea. I'm treating a problem that is in the mouth and that could be associated with that problem that the child is presenting. So, if we start working with children, we start looking at the dental arch morphology, right? And we have evidence saying children with obstructive sleep apnea had a significant increase over jet, a reduced overbite, a narrower upper and shorter lower dental arch. So children that have a severe problem because an obstructive sleep apnea fully diagnosed in a child is already a big problem, right? So they are telling us in the literature, in this paper, in 2009, that there is an association between the structural problem and the obstructive sleep apnea in the child. And if we go for more evidence, we can see that the facial morphology in kids is associated with mouth breathing problems and with snoring. And we see that Ali is telling us that the long face and reduced nose prominence and a retrognatic mandible may be diagnostic facial features for the sleep and breathing disorders. So they are showing us that there are structural problems affecting the airway. And those problems are part of the dental problem. The dentist should look at that. And we have facial patterns in primary nocturnal enuresis in children, and we can see that the prevalence of the dolichofacial pattern among anuretic and control group children, they look for this, and they look for the position of the head, and they try to correlate if there is sleep and breathing disorders and patients identified with PSGs could have any of these problems. And they concluded that bedwetters show different sleep habits, higher prevalence of dolichofacial pattern, again, a craniofacial structural problem, and abnormal head posture more than contrast. And Christian Guilleminault, that many of you may know, Professor Guilleminault was working in Stanford. Unfortunately, we lost him a couple of years ago. But he has been probably the professional in this area that has been calling the attention, calling the dentist to be aware of all the problems in the mouth associated with these sleep and breathing disorders. And he is telling us that in non-syndromic children, specific genetic mutations are often unrecognized early in life and affect the craniofacial growth, altering functions such as suction, mastication, swallowing, and nasal breathing. And all these structural and functional problems are associated with the appearance of at least a breathing disorder. So we can see that we have evidence to show that if we have a structural and a functional problem in the mouth, could be associated with those sleep and breathing disorders that the patient is presenting. So if I treat those craniofacial structural problems and those functional problems, in other words, if I treat the malocclusion that I have in a child, and if I treat the functional problems, the mouth breathing, and the incorrect swallowing, and the incorrect tongue posture, I can give the chance to the child to develop a better airway and to correct the problems that we have as in sleep and breathing disorders, right? And again, I am not treating obstructive sleep apnea. I am treating the mouth. And the mouth is giving me the opportunity to give the patient a better airway. And Professor Guilleminault was the first one to start calling the attention of the ENTs and the dentists and all the health professionals, saying that the tonsils and adenoids, hypertrophic tonsils and adenoids, most likely is not the cause of the problem. Most likely could be a consequence. And we will elaborate a little bit on that. So at this point, we can say that there is an association between a disturbance in the craniofacial complex and the airway. So we have support of the literature, we have evidence saying that the craniofacial structures impacts the size and shape of the airway. So if I have a patient like this, what happened in this patient? And let's start thinking about a little bit of the anatomy. If I have a patient like this, every dentist is going to say, oh, that child has an anterior crossbite. But what is happening with that child? In this anterior crossbite, the maxilla is retruded. If the maxilla is retruded, what is happening with the maxillary sinus? It's reducing the size. What is happening at the back of the maxilla? What we have? We have the nasopharynx. If the maxilla is moved backward, we are blocking that airway. So if I correct the structural problem, I give an opportunity to open that airway at the back. What happened in this patient that I have a posterior crossbite? What is the size of this this maxillary sinus? It's going to be reduced. So the flow of the air on this side, on the left side of the patient, is not going to be good. because the patient doesn't have a structure on that maxillary sinus to flow the air through. If I have a deep bite in a patient, the mandible is retruded. If the mandible is retruded, the tongue is backward. And if I have the tongue backward, I am blocking the oropharynx. And what happens in a case like this? Everything is blocked. The maxilla is totally narrow, so there is no passage of the air through the nose because the maxilla is totally collapsed. And remember, the maxilla is the roof of the mouth, but at the same time is the floor of the nose. So we have to think in the anatomy, what is happening in the mouth and how the mouth is affecting the structures around, not just concentrating in the mouth, right? So we are seeing sleep problems. So as I was saying, the maxilla is the roof of the mouth, but at the same time is the floor of the nose. The soft palate is the posterior limit of the mouth, but at the same time is the anterior wall of the nasopharynx. The tongue, a very interesting organ in the mouth that we don't pay too much attention, the tongue, the base of the tongue is the anterior wall of the oropharynx. So any treatment that I am doing to change this is going to impact positively or negatively the airway. So if I correct the structural problem and I correct the functional problem, I reestablish a nasal breathing, I reestablish a correct position of the tongue in the mouth and a correct dynamics of the tongue, I'm going to improve the airway for the patient and probably give a better airway to the patient. So let's see a case. This child was a mouth breather. You can see that he is with the mouth open most of the time. The tongue, you can see that is sitting on the floor of the mouth, is not going to the palate, and he has a very narrow maxilla, a very narrow mandible. So we have a structural and functional problem. And the parents were reporting that he has issues sleeping. So we start treating him and developing. I'm not going to talk about techniques, but I'm going to show you how the kids develop. And you can see how we can start developing the maxilla, developing the mandible, creating a correct nasal breathing, and now he can keep the lips together and breathing through the nose, improving the position of the tongue, and we continue developing. Now the patient entering in permanent dentition. He continued to develop. We start producing more maxillary and mandibular development with some kinds of appliances that is known as the alpha appliance. And we worked for a while with him, and you can see that he is developing everything. Now we are improving the overbite and the overjet. He is not breathing anymore from the mouth. He's sleeping much better. And he reached this situation. And then 2 years later, we are in this situation, just waiting for the permanent dentition to continue entering to the mouth. And just following the patient and being sure that all the functions continue in a correct way. We didn't have room for the canines when we started the treatment in 2018. In 2020, we can see that the canines are now in a better position, the upper and the lower canines. And in September of this year, that we did a follow-up with the patient, we can see that the canines are coming. And I can tell you, I saw this patient a week ago, and now these canines are in the correct position. And the patient is telling us, I am sleeping very well, I am functioning very well, I feel very good. We treated a structural problem, a functional problem, and now the patient is feeling better, right? So what happened? I know that you are not getting the audio for this animation, but it's an animation that I developed and you can get in YouTube. The normal way of breathing is through the nose. In that way, the air is passing through the nose and it's cleaning everything, and it's going through the nasopharynx, oropharynx to the lungs. And we have the tonsils and the adenoids located here. And all the passage of the air entering through the turbinates and entering to the maxillary sinus is cleaning the air and is producing nitric oxide, which is going to maintain the airway pattern. If we breathe through the mouth, we are losing all the cleaning of that air. And what is happening? The only ones responsible for cleaning the air are going to be the tonsils and adenoids. And remember, this is a lymphoid tissue, and lymphoid tissue is a defense tissue. So if they are being attacked, they overgrow. And then it's going to block the passage of the air, and the patient is going to continue breathing through the mouth, because now the passage of the air through the nose is more difficult. To breathe through the mouth, the patient has to bring the tongue down, not going to the palate where the tongue should be. And in that way, when the tongue comes down, the action of the muscles on the side, which are the buccinators, are going to start pushing inward, and the maxilla is going to narrow. And then we have a malocclusion, right? And in that way, we are going to have a very narrow maxilla. Now we have the tonsils and adenoids very big, blocking the passage of the air. And people are saying, oh, the problem is the tonsils and adenoids. This is what Professor Guillemino was telling us. This is a consequence. The problem is the mouth breathing. The problem is the pushing of the tongue, because when the tongue is down, for swallowing, the tongue has to push to the front. And then we will have an open bite. Right? And we have a structural problem and a functional problem that is associated with that sleep and breathing disorder. So again, start looking at mouth breathers, because the mouth breather is associated with an incorrect tongue posture, opening the mouth, an incorrect swallowing, and affecting the development of the maxilla and the mandible. And again, the nose is for breathing and the mouth is for eating. And that's the normal physiology in our body, nothing else. All right? So this is a video that you can use. It's an educational video and it's available. So if we start looking how the maxilla and the mandible and the tongue can affect the airway, we can see that the airflow has to go through the nostrils, enter into the nasal cavity with all the turbinates and the concaves, enter into the maxillary sinus, clean the air, then passing to the nasopharynx and then to the oropharynx. So it could be blocked anywhere here in this way. So some patients can have a difficult breathing because the nostrils are very reduced, and those patients are the ones that you do the exercise and you put the tape here and they can breathe better. But if I have a patient with a very narrow maxilla, the maxilla is affect the size and the volume of the nasal cavity. It's going to affect the volume of the maxillary sinus. So a narrow maxilla can affect the nasal cavity. A retruded maxilla can affect the nasopharynx. If I move this backward, I'm going to reduce this volume, and the passage of the air is going to be more difficult. And if the tongue is positioning down, the tongue has to move backward. And when the tongue moves backward, it's blocking the oropharynx. So anything happening here may affect the airway. If I improve this situation here, I may improve the situation of the airway pathway. A big discussion has been for years, if we extract teeth, are we going to affect the airway? And there is a study for those people who are pro extractions for doing orthodontics. There is a study that they did in England and was published and saying that people with extractions for orthodontics, they didn't ask. A very small percentage of those patients asked for the CPAP machine in the later in life. But if you review, they are associating people who went to the insurance to ask for a CPAP machine, who had orthodontics before with extractions and who had orthodontics before without extractions. But not always everybody having sleep issues go and ask for a CPAP machine, right? So it's a little bit biased, that study, but we can see this study from Professor Guillemino. And what they did, they looked for patients with early dental extractions or for patients that were congenitally missing teeth. And they checked with the apnea-hypopnea index. And they say that our children with permanent teeth missing due to congenital agenesis or permanent teeth extraction had a smaller oral cavity known to predispose to the collapse of the airway during sleep and presented with OSA recognized at a later age. So today we cannot say that if we extract teeth, that patient is going to have obstructive sleep apnea. But there are a red flag saying be careful, because those patients could be a higher risk. So if I have a narrow maxilla, is associated with breathing problems. So if I have this narrow maxilla and I keep this shape, or if I develop and I produce a better, wider maxilla, what is going to happen? And then we start looking at different publications, and we review the literature, and we have Dr. Yoon from Stanford University that she is telling us that rapid palatal expansion treatment is associated with reducing airway lymphoid tissues. In other words, patients who have rapid palatal expansion, they start shrinking the tonsils and adenoids, right? And we have other people, Professor Pirelli from Italy, that they did patients with obstructive sleep apnea, and they show that patients with a narrow maxilla, they were a higher risk of developing obstructive sleep apnea in the future. And Dr. Villa, also in Italy, showed that rapid maxillary expander is an effective appliance for treating children with obstructive sleep apnea. The same in another paper that Professor Villa published in 2011 showed that rapid maxillary expansion may be useful approaching children with malocclusions and OSA, and is an effective treatment that persists even 2 years later. And Dr. Yoon showed that rapid maxillary expansion improved the nose score and internal nasal valve. So, in other words, by doing rapid maxillary expansion, the volume of the nose was increasing and the patient was breathing better. So, if we have a narrow maxilla, the treatment should be to develop that maxilla, to treat this patient and bring that maxilla in this way. So that is what the literature is showing us, not to keep this narrow maxilla, but develop that maxilla to get a better nasal airway. And we have patients like that at a younger age, right? And we can see that she had a very narrow maxilla and she had an open bite, the tongue on the floor of the mouth, and being a nasal breather. We start treating her and we start correcting the open bite, developing the maxilla, correcting all the structural problems and the functional problems in the mouth. And you can see now how that maxilla is. Now we have room for the canines without doing any extraction, developing the maxilla, and now the patient is reporting that she can breathe through the nose with no problem. Now we can see that she is swallowing with no problem. And we are gonna avoid any problem in the future. We are going to give this patient an opportunity not to develop other sleep and breathing disorders, not to develop an obstructive sleep apnea. And if we have a patient snoring, they normally have a narrow maxilla. And it's interesting because now the ENT literature is saying surgery in young children is necessary but cures the snoring only temporarily. If they remove the tonsils and adenoids, but they didn't treat the structural problem, and they don't retrain the patient for a correct nasal breathing, the problem is going to continue. So let's move to the other part of the mouth. What happens when we have a retruded mouth? Is there any evidence? And we have this paper from Dr. Villa that she is showing that patients, not obese children, right? Without obesity, they have, with orthodontic treatment and myofunctional therapy, they have a good improvement in the obstructive sleep apnea. And she is saying that orthodontic and craniofacial abnormalities are reported in pediatric sleep disorder breathing, and that oral appliances may help to improve the upper airway during sleep by enlarging the airway. If I can move the mandible forward in a patient with a retruded mandible, the tongue is going to move forward and the airway at the area of the oropharynx is going to open. And in that way, the patient can breathe easier, right? And Dr. Idrissa also is saying that mandibular advancement appliances over a short period can be beneficial for patients with sleep and breathing disorders. Remember, a patient with a sleep and breathing disorder is not an OSA patient. It's just presenting symptoms, mouth breathing, shortness of breath, and snoring, right? According to that paper that I showed you from the ENT Association. And this is my paper that I did a publication. We use a mandibular advancement appliance in children. And you can see we did a preliminary report, and you can see that patients with an AHI above 1, which is normal in children, is wrong in children. The normal in children is less than 1 per hour. Patients that have between 1 and 8, almost 9, apneas, hypopneas per hour, after using the appliances for, if I remember correctly, it was for about 3 months, just for a period of 90 days, we can significantly reduce. So out of the 9 children that we did, 8 of them came to less than 1 apneas per minute. And this one, that was the severe one, from almost 9, 8 point something, that patient came to 2 point something after 90 days of treating the patient with a functional appliance. So we have supporting literature saying that if we advance the mandible, we can produce positive results in children with sleep and breathing disorders. But if I say in the other words, if we have a retruded mandible, that can make the airway worse. So we need to move the mandible forward. And in that way, you can see in a very young children that we can start treating those children and having a better situation. This patient had a deep bite, and when you have a deep bite, the mandible is retruded as well. The other situation that we have to be aware is when we have a deep bite, there is no room for the tongue. So the tongue has to go down and backward, and it's blocking the oropharynx, right? And this is a very good book that if you want to read a little bit about the situation of the tongue. And you can see that we start treating that patient, and the patient start developing. Now we have corrected the deep bite. Now the patient has a better overbite that in children should be close to 0, between 0 and 1 millimeter of overjet and overbite, right? And we continue following the development of this patient, and the patient comes to this situation. You can see now how it's opening the spaces, so the maxilla and the mandible are developing correctly. And why the maxilla and the mandible are developing correctly? Because now the tongue can go to the roof of the mouth, and it's producing a good force for the development, counteracting the action of the cheeks, the buccinators, pushing inward. So this patient continued developing correctly, and we went from this situation to this situation. And now the patient is ready to receive all the permanent dentition, and the patient is breathing through the nose, is doing a correct swallowing, and all the airway is open, and the patient is saying that he's breathing better and he's sleeping better. So let's see on the other side. What if we start pushing backward? And if you remember, it was very common to use the headgear with the cervical anchorage here to push the maxilla backward in patients with class 2. And we have evidence saying that the cervical headgear significantly reduces the sagittal dimension of the airway during sleep. Not every time. So that is something that we have to be aware, because the literature is saying that the problem is during the sleep. So if we take a record, we take a CBCT scan and we measure the patient when the patient is awake, probably we don't see the problem. But the problem is when the patient is sleeping, right? And this other paper is saying that headgear therapy may contribute to the occurrence of sleep apnea when a strong predisposition as mandibular erectognathia to the development of the airway, hyperairway occlusion already exists. If I have a retruded mandible and I push the maxilla backward, I can make the problem worse. So we need to bring the mandible forward, not to push the maxilla back. So that's why in cases like this, we bring the mandible forward to achieve a better result. We don't want to do retrusive orthodontics because we may negatively affect. What happens when we have an anterior crossbite? When we have an anterior crossbite, the maxilla is retruded. So we don't want to bring the mandible back, we want to bring the maxilla forward. So we check what is happening with a patient, and we start treating the patient bringing the maxilla forward. And we can see that this patient starts developing with no problem. And we achieve this situation from here in March 2016 to October 2017. We corrected the anterior crossbite, the maxilla is moved forward, and you can see the patient is with the mouth closed, breathing through the nose with no problem. Then we continue following that patient until the patient enters into the permanent dentition. You can see that totally stable because we are creating a physiological situation in the mouth and in the airway. And we went from this situation to this situation, bringing the maxilla forward and opening the airway in the area of the nasopharynx. I have been talking about the position of the tongue, and I presented you evidence before that rapid maxillary expansion is good for treating sleep and breathing disorders and patients with obstructive sleep apnea. And in patients with nasal obstruction, not only the rapid maxillary expansion produces a better nasal volume, but also permit the tongue to go to the roof of the mouth. And by that, is improving the area of the oropharynx. So we don't use these. These are traps for the tongue. We use more functional appliances that give the room for the tongue to reach the palate and not to cage the tongue in the mouth. So for example, in this case, we have an anterior crossbite with an open mouth. With an open bite, you can see the tongue on the floor of the mouth. The patient is struggling to keep the lips together. You can see all the force here on the buccinators and the auricularis oris. And you can see that we are advancing the mandible. You can see the nasolabial angle when we started the treatment and the nasolabial angle when we finish the treatment. The maxilla is forward, not the mandible going backward. So in that way, we permit a better development for all the permanent dentition to enter and opening the airway at the back. So you can see how the patient is closing the open bite, the maxilla moving forward. The patient continued developing with no problem. And 2 years later, we are in this situation with everything developing properly and the patient saying that now she's sleeping much better and feeling much better, right? The other symptom that we may have in children is tooth grinding. And a tooth grinder is a mouth breather. And a mouth breather can have sleep and breathing disorders. And a child with sleep and breathing disorders can develop obstructive sleep apnea later. And you have seen all the evidence that I presented to you. So, is tooth grinding associated with the sleep and breathing disorders? We have this paper from Martinot in 2015 showing that mandibular movements occur frequently during the periods of obstructive sleep apnea. So when the patient is gasping for air, the mandible is moving forward and backward and is creating that tooth grinding. And this other paper is saying that mandibular movements can be one of the signs to start suspecting that there is a sleep and breathing disorder, because normally they occur immediately after the presence of respiratory effort. So we have evidence to say that tooth grinding may be associated with the sleep and breathing disorder. So you can see this grinding in the primary dentition. The patient has a deep bite, a retruded mandible, so the patient is having sleep and breathing disorders, not obstructive sleep apnea yet. Then we start developing everything, make the patient a nasal breather, a tongue posture correctly, and developing everything, and the patient is not grinding the teeth anymore. We create symmetry. You can see that the mid face and the lower face are asymmetric here, and they are more symmetric here, because we improve the vertical dimension of that patient. And the patient continues developing with no problems, and in the future, I hope, is not going to have other issues, right? So, we have, and I have presented to you, evidence to say that the structural problems in the mouth and the functional problems in the mouth may affect the airway. And if we improve that, we can give a better airway to the child, right? And it's supported by Dr. Juan and Professor Guillemino, that they are saying that all of this in none of these children is a disorder of orofacial growth. So if we have that, we need to start looking at the malocclusions and the functional problems as a potential cause of sleep and breathing disorder. So when we have a malocclusions, I diagnose in 6 dimensions. I diagnose the craniofacial structures in the sagittal way, in the vertical way, in the transversal way, in the coronal, and in the frontal way. Why? Because if I have a retruded maxilla or a retruded mandible, sagittal way, I may have a problem. If I have a deep bite or an open bite, I may have a problem. If I have a transversal problem, a lack of transverse development, I have a narrow maxilla, a narrow mandible, I may have a problem. If I have a cant, a coronal problem, the area of the higher side of the can may be affected and the flow of the air is not flowing correctly in that way. If I have a frontal problem, the maxilla or the mandible switched to one of the sides, I can be affecting also the airway in some parts. And also, I evaluate the functional disorders, the mouth breathing, where the tongue is positioned at rest, how are the tongue dynamics, how are the lips at rest, are they open or closed, and how is the mastication of the patient. So if I correct all the structural problems and the functional problems, I'm gonna produce a better results on the children. So, thank you for your attention. I want to make you aware. If you are interested in learning more about all these issues and the techniques that I use to correct all these structural and functional problems, we have a mini residency starting in February next year. And if you go to this website, which is our educational website, you can get all the information about the mini residency. We are going to have 4 modules, one in February, one in March, one in April, and one in May. And through these 4 modules, I may teach you all the techniques that I use to correct the structural problems. We teach you the myofunctional exercises that we do for the patient to reestablish a correct nasal breathing, a correct tongue posture, and a correct tongue dynamics. And all of this is treating the malocclusion and the functional problem in the mouth of the child. And that way, we are giving a better airway to the child. Thank you very much for your attention, and I hope that you found a little bit of this information interesting.
Thank you, Herman. I think while we're waiting for some questions to populate here, Barry, Don, do you have any questions about this topic?
Herman, I'm a little confused. After reading the AAO white paper published in 2019, where they critically reviewed the LIT down to methods and control groups and the lack thereof, and my reading says they came to a different conclusion than you have.
That's why we exist in this world. If we don't have different opinions, we don't exist. And I showed you the evidence. I show you probably 20 papers today against one. And actually the white paper is saying that we dentists, they don't say we dentists, they say orthodontists should screen for sleep and breathing disorders, right? So they don't accept, but they also say you should be aware of this problem. And this is something that we are getting publications every single day. One showing results, some people showing no association. But again, and I want to make that clear, and that's why I'm saying from the very beginning, most of the papers are looking for obstructive sleep apnea in children. They are not evaluating the signs and symptoms of sleep and breathing disorders. And remember, in children, and that is another problem. When I say children, I am talking from 0 to 15 years old kids. What is the population that the studies are evaluating? If I am talking about rapid maxillary expansion, I have to go for some permanent dentition. So I have to evaluate children 8 to 12 years old. And that is the lower incidence of obstructive sleep apnea. But those patients are still mouth breathers. So I have to evaluate all the variables that I have in there. When I have a child, normally the higher incidence is between 3 to 5 years old. Then it declined a little bit, and then it increased after 15 years old, 18 years old. So I am evaluating obstructive sleep apnea, I am evaluating sleep and breathing disorders, and the ENTs, they are telling us they are two separate entities. So that's why I'm remarking, look for mouth breathing, look for tongue posture, look for incorrect swallowing, and in that way, you are going to evaluate symptoms of sleep and breathing disorders. If you are going to evaluate for obstructive sleep apnea, go for a PSG. Okay?
I think there's a concern, it's really well done, thank you. Here's a concern. There's a concern that almost as there are some statements made that suggest a direct relationship between anatomy and breathing. And I know you don't mean that. I know you don't mean to suggest that if someone has a crossbite, therefore the maxillary sinus is smaller and there's a breathing problem. There are many people with crossbites that either may not have a smaller airway or smaller sinus and no breathing problem, and people with a smaller sinus and a crossway with no breathing problem, and people with a large airway and a breathing problem. My concern, and I know Don's concern, is the new emphasis in airway dentistry, as though this is something new and brand new, and you are living proof that it's not. To suggest that this is new, but to simplify and dumb down and make generalized assumptions that can lead to incorrect conclusions, or in some cases overtreatment, or the assumption that therefore if I see someone with and you've done this well, you've combined signs and symptoms, but there are those suggestions that if we don't correct this on an early age, that we are going to lead to problems. No, that's not true. So, or that if we see this, that there's if that crossbite exists, then therefore that sinus is going to be smaller, and that's going to be a problem. I know that's not what I'm confident. That's not what you're saying, but that's sometimes what is heard. Does that make sense?
And yes, totally makes sense. And it's something I will have to enter in a field that is a little bit rough for dentists, for clinicians, and I have to enter in a little bit of statistics. Association doesn't mean correlation. What the literature is showing
causation. It means correlation. It doesn't mean causation.
Association doesn't mean causation, and association is different to correlation, right? And the literature today is telling us it could be an association. There is no causation, right? There is no paper saying definitely it's a correlation between a structure and airway. There is no paper on that.
Because it can't be.
It's impossible. Right. And probably we will see 10 generations after us, and we will continue with this discussion.
Herman, are you aware of any twin studies on this?
No. And we have been discussing this with John many times, and I was telling him, I am correcting the malocclusion and the functional problem. I am a dentist. I am not a physician. I am not an sleep physician. I am treating the structural problem and the functional problem that the literature is showing me that could be associated with the sleep and breathing issues, and that may become worse in the future. So by correcting the malocclusion and correcting the functional problem, I am giving the opportunity to the child to improve the airway and to continue developing the airway the best that we could, and probably not having problems in the future. But I cannot say I'm treating the breathing issue. I cannot say I'm treating the obstructive sleep apnea by putting an appliance in a child.
I can't tell you how great that is to hear, and I wish that more of those that were teaching orthodontics and airway issues were as astute and as clear on that point as you've been. That's the assumptions that are being made at this point. GM&O is the one who very early started talking about in our extremely young kids that were very, very ill, including some form. Well, the first, as you know, they were very aggressive with their surgery, but eventually he got back to functional orthodontics and myofunctional therapy for his kids, and there's there is real evidence that there's a place for it. It's just the overwhelming the generalization statements, and that's what I jumped on. Make sure that we understood there was a thought process that it may be, and you made that many times. And then what's worse is now, and again you pointed this out from the beginning, the carrying out and the assumptions of the direct relationships between structure and obstructive sleep apnea and adults, and this new emphasis on correcting airway in adults by altering their occlusion and improving their airway.
I have in my office. I have a lot of patients that they come referred by other colleagues, and they refer the patient for me to put a palatal expander because the patient have sleep and breathing issues. And I say, why am I going to put a palatal expander if the problem is that the mandible is retruded and the maxilla is well developed? But he has a sleep and breathing disorders. You have to put a palatal expander. Sorry, I don't have to put a palatal expander. I have to move the mandible forward and correct that structural problem and probably giving a better way to the child.
So I have to say that last statement, along with everything you've been discussing with Herman here, I think that was probably the most important part of the whole session, because it helps to lend credibility, I think, to what Herman is talking about. He's not overstating anything. It is what it is, and this is how we can perhaps be improving things for this child. And we're not necessarily treating sleep apnea. That's not what the end result. It may impact on that, but
not necessarily treating, but not necessarily preventing.
Right.
Not necessarily preventing. And the thought that we've got to take every kid and listen. The attacks that have been made on orthodontists who have been doing serial extractions because that was what the training was, and the fact that there still are some, does not necessarily mean that they are practicing malpractice while they're doing it. And I've got dentists standing on that are from Canada that are teaching this, that are saying that out loud, that these people should be stripped of their licenses. I mean, it's really upsetting. And it's not fair, and it's not true. And Herman never said that.
And what I will say is, by correcting the structural and the functional problems, you are reducing the risk of having other problems. But
I don't think anyone can argue with that. Absolutely.
Yeah. Let's hop on some of the questions that our attendees have posted, please, Herman. If an adolescent child has a retruded mandible but does not display evidence of snoring or mouth breathing, is this still beneficial to use appliances to advance the mandible?
Yes, because we are correcting a structural problem, and it's not only a retruded mandible, it's how the position of the tongue. I can see mouth breathers, adults, that they are not having sleep and breathing disorders issues, but they are struggling to life because the mouth breathing, right? And if I have a retruded mandible, it may be associated with a mouth breathing. And if I have a child, probably at that moment, the child may have a symptom like restless or having the mouth open during the night only, but still not having a big issue. And again, if I correct that structural problem, I may reduce the risk of that patient developing something in the future. I cannot guarantee that patient is going to be an OSA patient, yes or not. I cannot guarantee that accommodating the mandible in a good position is for sure prevent any issue in the future, but I am giving a physiological situation to the mouth where the mouth should be. And the mouth
Let's put it another way. Let's put it another way, Herman. The child comes to you and is a patient of yours, and or is being referred for an evaluation because he's been told by his general dentist if he does that he needs orthodontics to prevent, because he's got a retruded mandible and this is going to lead to a problem, and he needs orthodontics to prevent an eventual obstructive sleep disorder breathing issue. The parents bring that patient to your office for that evaluation.
I will be totally clear to the parents that we need orthodontists to correct the malocclusion. But there is no evidence today to show that because the patient has a retruded mandible, he's going to have obstructive sleep apnea. That by correcting that malocclusion, I may reduce the risk of that patient having some sleep issues in the future.
Can't be said any better. It can't be said any better. The fact of the matter is that if you're going to do orthodontics, why not do it right? But if you're not, but to tell that patient that they need orthodontics in order to prevent it, if they're not going to have orthodontics, so
it's
be
totally
it.
wrong. It's totally wrong. I agree with that.
Okay. Next, thank you. Excellent lecture. Any online courses on the same topic?
Well, all right. Because COVID, we had some online courses. We did the mini residency online, but I can tell you honestly, if I want to teach you, doing in-person training is the best option. So the course that I show, the course that I show you that we are starting in February, is going to be in person, and in that way I totally interact with you and teach all the techniques in the correct way that should be done.
8 minutes away from the Toronto International Airport, for those of you that are flying into town. Okay, so next, at what age should you start treatment with the unilateral anterior crossbite?
As soon as I diagnose the unilateral crossbite and the patient understands what I am trying to do. I have done start a treatment based on age. I need the patient to understand. I have 3 years old that they perfectly understand and collaborate with me to do the treatment. I have 10 years old that they don't understand anything and they don't collaborate. So the age is not the rule. The rule is that the patient, we diagnose the problem and the patient is able to cooperate. So I have patients correcting a crossbite at 3 years old. I have one of my publications in the Journal of Clinical Orthodontics in 2003 that I am showing a case that I corrected the posterior crossbite in a 4 years old kid. The age is not the goal. The problem is that the patient is able to cooperate.
Okay. Next, whether the patient presents with a retruded maxilla or a retruded mandible, is it a random as to which one they have?
I have to do a diagnosis. I have to take a CEF to understand what's going on with the patient. I have to evaluate the patient and to see what is the problem.
So maybe I'm misunderstanding the question, but I'm thinking he's asking which is more common.
Oh,
I think that's what.
It's more common probably to see a retruded mandible the maxilla needs a little bit more of observation and diagnosis to understand that the maxilla is retruded.
Next, do you get PSGs on any of the children? I ask mainly because people put a lot of emphasis on its contents, whereas in my opinion, it makes sense to do what you have to do to allow the tongue to assume its rightful position. Expand the palate, lower the palate, the power of 4 helps you get out of a lot in the early stages of the treatment, I would think.
Again, I say I'm a dentist. I'm not a sleep physician. If I see that the patient may benefit from a PSG, I will try to contact a sleep physician to do a PSG and to do all the evaluation and do the full diagnosis. I'm not a professional to diagnose anything on that, right? I'm diagnosing the structural problem and the functional problem. And I will treat as early as possible. Some patients come to me with the diagnosis from the sleep physician directly. And if I don't have any suspicion or anything, and I see a structural and breathing problem. And the other thing that we have to be aware is that the patient, again I say, has signs and symptoms of obstructive sleep and breathing disorders, but the parents are not reporting that the patient is doing apneas or hypopneas during the night, that is choking or stopping breathing. We can do the structural and functional correction and to see, and if we consider, we ask the sleep physician to do a full evaluation. But it's not me who is going to do that.
How do you objectively assess the 6 parameters?
I have to do a clinical evaluation. I have to take a set, a pan, do some measurements. I have to do a functional evaluation. So it's not my initial evaluation is not the common evaluation coming to the office and looking at the mouth by the dentist and saying, oh yes, you need appliances. I need to do the full diagnosis to evaluate what is happening with the patient and give a correct treatment plan to the patient and the parents.
As a myofunctional therapist, how is it important to have a myofunctional therapist in your office? So how important is it to have a myofunctional therapist in your office?
Well, let me answer in this way. I have 2 in my office. Every patient that sees me sees the myofunctional therapist every time that they come to my office.
Yeah. As a matter of fact, you felt it was so important you had your wife become trained as a myofunctional therapist. That's a pretty high vote of confidence. Okay. How is the malposition of the maxilla or mandible due to restricted tongue movement? How often is the malposition of the maxilla or mandible due to restricted tongue movement?
There is in both ways. For example, if we have a restricted freeing of the tongue cannot go to the palate and can be causing problems of the development of the maxilla. Or if we have a narrow maxilla, the tongue is going to go down. So to tell is 80%, 90%, I don't know really. I cannot say a number. But yes, we have to do all the functional evaluation to understand that.
Well, great. We've reached the end of the questions. Don, Barry, is there anything that you wanted to add to this? Herman, that was very enjoyable. Thank you very much for spending this time.
No, the clarification at the end is wonderful there. Thank you.
Thank you for all the evidence-based approach that you take. I really do respect that and appreciate it. And look forward to...
John, I will comment, John, real quickly about that. I think, and Herman knows this, you got to be really careful with evidence-based in an hour presentation.
Right.
What we're looking at are abstracts highlighted. So there was not, I couldn't possibly follow the methods and the valid, and there's some real questions about the validity of some of those studies before, what was it, 2016, 2015, Don?
2019, the white paper was published. So probably through 2008, they looked at.
So I'm not criticizing at all. I mean, we all do this. So I'm just, but
I can tell you, Barry, that I can read all those papers. And I have all the papers, and I can share with you.
Dr. Glassman, we'll send you the screenshots.
Sorry?
We'll send you the screenshots.
I don't need the screenshots. I've got them all. And we'll be reading them. It's all good.
One of the things, Herman's taught at the University of Manitoba on faculty there. And then where did you teach in the States? Which university were you associated with there?
At this moment, I have a course of sleep dental medicine for the ortho and pedo students at Loma Linda University in California. We have incepted this course. It has been 3 years now, and I am teaching them all the craniofacial growth and development and all these concepts, how they can treat the malocclusions and the functional problems to improve and give a better way to the patients.
Now, this may be naivety on my part. I'm not sure, but I'm sure a certain amount of vetting goes on, at the university level before they go ahead with a program like that. So, I mean, that's a vote of confidence there. Just saying.
I'll give you some examples of some people who taught at universities, and you may not.
Yeah, but we won't mention him because there's only really one that you're really talking about. Anyway, thank you very much for everything. Thanks everyone for attending, and please fill out the short questionnaire when you're finished the webinar, and you'll get your CE point emailed to you. And look forward to seeing you at our next presentation. Thanks everyone.
Thank you, everybody.
Thank you.
Thank you, Dr. Ramirez. That was amazing, and we're looking forward to having you next year.
Thank you. Thank you. I will be glad to be in your facility teaching all these concepts.
Yeah. So that's that's very exciting. Something to look forward for the new year. Thank you so much.
Good night.
Thank you. Bye.